Hello, good morning and good evening, friends, speakers and chairs in different parts of the world. We are back again with another session of ACNS webinars. We have two great talks lined up ahead for you today. The first speaker for today is Professor Eckhard Casper from Canada. Professor Casper is a professor and head of services, Department of Neurosurgery, Hamilton General Hospital, McMaster University, Ontario, Canada. He was a previous alumni and faculty at the Harvard Medical School, USA. Professor Casper was a previous director of the brain tumor program at the Beth Israel Deaconess Medical Center. In addition to his reputation as a very skilled surgeon, he is also a noted figure in the field of research and publications. He has more than 200 peer-reviewed publications to his credit and is the author of several reviews and book chapters. He is a reviewer for more than 35 scientific journals and is a member of the editorial board for many acclaimed journals in neurosurgery. We are extremely honored and thankful to him for accepting our invitation to be a speaker at our webinars. Today, Professor Casper Eckhard is going to talk about surgery for intraventricular tumors. The second speaker for today is our honored guest from China, Professor Xu Feng. Professor Feng is Associate Professor, Department of Neurosurgery, Huashan Hospital, Shanghai Medical College, Fudan University, China. He was a previous fellow with Professor Ali Christ at the Arkansas Neurological Institute and was also a skull-based fellow of the Department of Neurosurgery, University Hospital, Case Medical Center, Case Western Reserve University. We are extremely honored and thankful to him for accepting our invitation to be a speaker at our webinars. Today he is going to talk about classification and surgical strategies of clipping anterior communicating artery aneurysms. The chair for today's webinar is our honored guest from Mexico, Professor Jose Antonio Soriano Sanchez. Professor Soriano is one of the most prominent faces in the Mexican neurosurgery. He is affiliated to the Centro Médico ABC Santa Fe, Coajimalpa de Morelos, Mexico. He is the founder and president of the Inter-American Society Minimally Invasive Spine Surgery. He has also served as the past president of the Mexican Society of Neurosurgery. He has received several awards and honors during his vast successful career for his contribution towards neurosurgery. He is a noted author who has published several articles in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation to be a chair at our webinars. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. A special thanks to Professor Shubin for being our mentor and supporting the ACNS webinars and arranging speakers for us. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over the platform to Professor Jose Antonio Soriano Sanchez.
Thank you. Good early morning from Mexico, in Latin America. Good night in Japan, in Asia. It's my pleasure to welcome all of you for this magnificent neurosurgical webinar organized by the Asian Congress of Neurological Surgeons. First of all, I would like to thanks to the organizer committee by the kind invitation to participate as chair. And also, I want to emphasize my personal recognition to one of the greatest neurosurgeons around the world, Professor Yoko Kato, current president of the ACNS, and who has been example to follow and has had the initiative and the leadership to conjoin a world-class group of neurosurgeons from different parts of the planet to share the knowledge in different scientific programs that includes select topics that every neurosurgeon should know, and at the same time, it has had the virtue to promoting and strengthening the bonds and brotherhood between the ACNS and the Latin American Federation of Neurosurgical Societies. Of course, our deepest thanks to the outstanding professors who kindly are making the great effort to share their wisdom knowledge today. Firstly, Professor Eckhard Casper. Without further comments, I give the floor to Professor Eckhard to present his lecture on the surgical treatment of intraventricular tumors. Thank you, Professor Eckhard. Go ahead, please.
So, thank you very much for having me. I want to express deep gratitude to Yoko Kato and Franco Servadei, who have really encouraged me to participate in the Asian Congress and these activities. It's a pleasure for me to contribute with the talk on modern aspects of intraventricular tumor management. I have nothing to. My agenda is to give you a brief general introduction over brain tumor surgery and intraventricular tumor epidemiology with a few diagnostic methods. And this is because I don't know what level the residents are that participate in today's seminar. And then I want to give you some surgical scenarios for intraventricular tumors with the focus on meningiomas in the lateral ventricle, the colloid cyst in the third ventricle, and the telovela approach for the fourth ventricle. And then we have some time for discussion. So brain tumors in general remain a rare disease and constitute only about 2% of all cancers, which makes about 70,000 brain tumors annually in the United States for a total of about 1 to 2 million cancers. The lifetime risk for anyone to develop a CNS malignancy is only 1%, but the overall incidence of tumors seems to increase and affects more Caucasians than Afro-Americans, Latinos, or Asians, with men more frequently affected. The clinical presentation is rarely brain tumor specific, but really specific to location. There are general symptoms such as headaches, nausea, vomiting, dizziness, and seizures that we all know about. More leading for diagnosis are focal symptoms such as weakness, sensory changes, or on the dominant side, aphasia, as well as visual compromise and P. fossa symptoms such as tinnitus and apraxia. So for most general care providers who meet the symptomatic patient the first time, they should order a CAT scan as soon as possible. This is a typical vignette of one of the patients coming from a primary office. A 42-year-old female had an unremarkable past medical history, but then became forgetful for about 3 months, had mild problems with balance, vision subjectively a little blurred, increased thirst and urination and some fatigue. And the primary care physician initially got some labs, which were normal, but then decided to get a CAT scan, and this is what it showed. There was a large suprasellar mass, possibly extending into the third ventricle, measuring about 4 by 4 centimeters. There were cystic and solid components, no calcifications, no hydrocephalus yet, but the primary care physician was concerned enough. And the question, first of all, was what's the differential diagnosis and what to do next? The differential diagnosis for a lesion such as this is really wide. It's based on both clinical exam, laboratory data, and imaging, and anything is possible. So here in this location, from a metastasis, glioma, meningioma, more likely maybe pituitary adenoma or craniopharyngioma, essentially everything is possible. And this is a patient that should be referred to a brain tumor center. Now, my brain tumor center in Boston was organized around neurosurgery. It's a comprehensive tumor program that from the very beginning for every patient advocates for integrated multidisciplinary management. And we have done the same here at McMaster. So we meet as a team of neurosurgeons with radiation oncology, neuro-oncology, medical oncology, and neuroradiology and pathology present at every conference. And we call in addition, the pituitary group as needed once or twice a month, and the skull-based group once or twice a month. The way it works is we have a patient-centered care of work, which is a one-stop shop for the patient. So there's a morning conference where we review together around a big table all incoming films and discuss next steps. And then we see the patients in an all-day clinic with full assessment by the nursing staff and all subspecialty MDs as necessary. The patient actually stays in one room and the doctors rotate, so the patient doesn't have to go to various clinics to see the necessary subspecialists, and that helps a lot with efficiency. Basic tumor diagnostics are not different from any other intracranial workup. CAT scan, in this case, posterior third ventricle tumor shows a dense lesion. On the MRI scan, you see a solid and a cystic component. It's peripherally contrast enhancing on MRI scan T1 sitting in the pineal area. On the gradient echo, you see there was a previous bleed associated with it. It's not DWI restricted. It's not hypervascular. So this is all good information that gives you clues what you're dealing with. Occasionally, we add in CTAs or formal angiograms. We rarely use advanced tumor diagnostics in ventricular tumors, but occasionally you have MRI spectroscopy, perfusion studies, or even PET and SPECT available. This is more helpful if you want to do a biopsy only, or you have a patient with underlying systemic disease, and more frequently used for parenchymal tumors. So how do we diagnose these tumors? First of all, comprehensive anamnesis and systemic assessment remains pivotal, and radiographic assessment is really the stethoscope for the neurosurgeon. we need brain imaging, and if we have torso imaging in a patient with systemic disease, the gold standard remains to get a tissue diagnosis through histopathology. That can be obtained through CSF cytology or from direct tissue samples. So going back to our patient here with the third ventricular tumor, CSF studies are a treasure. This patient received an EVD. You could also do an LP if there's no hydrocephalus involved. You can send these off for tumor markers to rule out the typical culprits such as germinomas or other developmental tumors, but always send them for cytology. You may be able to get a diagnosis without a resection in some cases. And for lymphoma, for example, a germinoma, that would be helpful. The patient is usually more interested in his options, not so much in the name of the tumor. And I always go through the entire list with each patient, from wait and observe over surgical intervention, possible radiation therapy, options for chemotherapy in some cases, and more recently evolving options such as minimal invasive stereotactic delivery and interstitial brachytherapy. But this is beyond the scope of this talk. You really know what you're dealing with to give the patient a proper consultation. So patient, again, is more interested in the risk of surgical treatment than anything else. And here I make it simple. I tell the patient, I really don't know the risk until I've been there, because that's a delicate area, but don't be afraid. The risk is not worse than any other surgery, such as in orthopedics when you get a joint replacement. And I actually mean that, because the statistical risk is at about the same magnitude of 5%, and the symptoms would be rather similar depending on location. So I think the most important thing here is the patient needs reassurance. What are the risks? Problem is, most studies define them for the purpose of their study separately. We should have a general catalog of complications, and then everybody should classify it the same way. I like this paper by Grondin's group from 2007 that basically separated major complications, which are permanent neurological deficit of any kind at all, versus minor complications being transient neurological deficits, or any other deficit and problem that has transient management changes with it. And that helps to give the patient a baseline idea. Now let's go through intraventricular tumors in particular. Let's go through the problems, the available options, risk for each of these, and a roadmap to success. So are intraventricular tumors actually a problem? Yes, because 1% are located strictly in the ventricle and most frequently in the trigonum or atrium, and that's a deep-seated buried area. But no, because 10% of all brain tumors involve the ventricles. So you need to know your anatomy and how to deal with this. Are these intraventricular tumors a challenge? Again, yes, because it's rare disease, especially early in your career, and it's surrounded by high real estate. So getting there and your experience will help you to deal with this. And at the beginning of your career, experience may be lacking. But no, it's not a challenge. But if you follow some basic principles and stick to what you know best, it really works. And there are many options out there. You just need to find the suitable one. It starts with classification of the lesion, which you should do by radiographic features. And they are good for delineation of the lesion, but they're usually non-specific. So it helps you with the approach, but you may still not know what you're dealing with. Location of the mass and the patient's age provide the most helpful information in the differential diagnosis. You will see that in a second. Best thing is to start with categories. Is the lesion solid versus cystic or mixed? And is it a neoplastic lesion, or could it be something else? A non-neoplastic lesion, such as a parasite in the ventricle, may change your course of disease substantially. Once you classify lesions, it's useful to use subdivisions based on the site of origin. Tumors originating from the ventricular wall and septum pellucidum fall more into the group of ependymoma, subependymal giant cell astrocytoma, rarely neurocytoma. Lesions strictly located in the choroid plexus, in pediatric patients more likely to be papilloma or plexus carcinoma, and adults more likely to be meningioma, solitary fibrous tumor, or else. And if they are mixed and can't be delineated so well, it can be a whole host of other lesions, and that's where you really need a tissue diagnosis. Clinical presentations are somewhat complicated. They're usually non-specific, which makes intraventricular tumor mostly a late diagnosis. In the lateral ventricle, you need to know the syndrome of the trigone, which is a mixture of weakness contralateral to the lesion in combination with hemianopia, and on the left side dysphagia. And if the tumor is large and there's mass effect downward, you may see cerebropeduncle symptoms and weakness. You may also see obstructive hydrocephalus, which can be unilateral in an entrapped temporal horn or bilateral from a frontal lesion. In the third ventricle, it's more subtle, and you may have hydrocephalus with memory trouble, some visual decline, and endocrine problems. But in children, there's a distinct syndrome called the emancipation and hyperalertness syndrome. And in the fourth ventricle, it's largely brainstem and cerebellar symptoms, often in combination with obstructive hydrocephalus. So again, all pathologies are possible. For today, I want to focus on meningiomas and on the colloid cysts. This is my management outline for typical scenarios. If the patient comes to me and it's a truly incidental finding, let's say the patient was scanned because they fell down the stairs, they find a tumor in the ventricle and the patient is truly asymptomatic, you need to hold back your horses and not do anything. You cannot make a patient better who has no symptoms. As much as we think we are a talented surgeon, I treat patients once lesion is progressive and has been documented on 2 consecutive scans. And then you have all techniques available, open surgery or minimal invasive. More likely the patient comes in as a non-incidental finding and is somehow symptomatic. And in principle, all patients should be considered surgical. In rare cases, end-stage metastatic disease or intractable cardiovascular disease or anticoagulation, you may decide to either do nothing or do radiosurgery based on best guess. Now let's talk about options for the surgical routes. There are many open routes. You can also go endoscopically. Then you can think about minimal invasive treatment. To make the best decision, you really need to know your anatomy and topography. I still study every single patient the night before for many more hours than the actual case. And here I don't save. I get every available imaging technology on the market, CT with vascular studies, MRI scan with functional studies if on the left side, DTI if you have tractography available and 3D surface rendering to get good access points. Helpful, not necessary, but use intraoperative image guidance, especially in the early phase of your career. This is one of these lesions. You see the cauliflower lesion here in a flipped navigation image. So it's on the left side, dominant cortex. It's multilobulated. It's hypervascular in a certain portion of the tumor. If you rotate this nicely on your image guidance system, you can get a good visual about how to get to this tumor in a good location. So this is a challenge and you need to know what to expect. So if you get into the ventricle, looking from the left side into this patient's occipital horn, the choroid plexus glomus is right in front of you. Thalamus is deep to it, down. Body of the lateral ventricle is above you, deep into the field. Corpus callosum is midline. The occipital horn is opened, and the floor of the occipital horn is formed by the cornea communis and hippocampus formation. When you lift up the choroid plexus, you expect the choroidal fissure and the fornix beneath it. So this is your higher real estate, and don't ding the putamen of the thalamus when you work in there. So this is one paper I want all learners to pull out and read. It's by Kawashima, who nicely described how to get into just the atrium of the lateral ventricle. What are the different approaches available to all of us? What are pros and cons? And I think it's a good paper because it tries to solve a problem that I describe as the bird cage. You really try to steal a bird out of a bird cage deep inside the brain without opening that cage too much and not violating it. So again, as I said, let's focus on meningiomas, which is a problem that has been known for about 150 years. Intraventricular meningiomas make up about 1/3 of all intraventricular tumors, but only a small percentage of all intracranial meningiomas. And until 20 years ago, only about 500 cases have been reported. At this point, it's maybe twice as many. There seems to be a gender predilection for females, just like in general meningiomas in the second half of life. But note a marked difference in prevalence depending on the age. In children, intraventricular meningiomas are much more frequent and make up to 12% of intraventricular tumors. Now, Intraventricular meningiomas develop in the lateral ventricle in 80% of cases, with the predilection for the left side. Nobody really knows why, but you need to know the dominant side here really well. In adults, only 15% occur in the third ventricle, and in the fourth ventricle, a meningioma is really a rarity. I recall 2 cases in my career where it clearly was meningioma that did arise there, but it's almost a reportable event. You need to know that they originate from stromal cells of the choroid plexus, and they are fed by choroid plexus vessels. In the lateral ventricle, these vessels come from the PCA and are called the lateral posterior choroidal arteries. In the third ventricle, it's the medial posterior choroidal artery that feeds them, and in the fourth ventricle, feeders come usually from the pica, and this is the matching image. The most common histopathology of meningiomas in the ventricle is benign and fibroblastic. Non-benign intraventricular tumors are exceedingly rare, less than 1% from meningiomas, and the transition from non-malignant to malignant is also rare, about 2%. In the first 10 years of my career, I did about 12 of these, and I once pulled the data together and looked at them. They just followed the general distribution, and I want to give you an example, right versus left. So this is a right-sided lateral ventricle tumor in a 47-year-old patient who presented with just episodes of restlessness, followed by a headache. And because he was anxious, he had some arrhythmia and palpitations, and he was worried about an MI, so he went to an outside hospital. On admission, completely non-focal. Review of systems didn't reveal anything except some intermittent lightheadedness, so they were worried about an MI or stroke and ordered him for a CT-CTA, which revealed this 2.5 centimeter homogeneously contrast-enhancing lesion in the ventricle with an entrapped temporal horn. So it's not truly incidental. Because they had him worked up for stroke, he did get the perfusion studies, and you see how hypervascular this lesion can be. Homogeneously contrast-enhancing hypervascular in the trigonum. This is almost pathognomonic for a meningioma. You see the vessel, the pedicle is displaced inferiorly as well as superiorly towards the choroid plexus. What did we do for this man? There are 2 options. The favorite approach is either a right superior parietal lobule axis or through a right mid-temporal axis. Both of these have advantages and disadvantages. Coming from the top, low risk of hemiparesis, smaller risk for visual field defects, but on the dominant side, higher risk for cognitive problems. Coming in from laterally gives you earlier control over the vessels, which may be sometimes an advantage. Low cognitive risk, but higher risk for visual field defect and paresis. So this works better on the right side. I personally prefer the superior parietal lobule axis on the right side and try to go through a sulcus. Relatively small bone window, you find your way in. Digging out this tumor was technically not complicated, and we were able to do a very safe, very familiar, straightforward approach. The operation takes about 2.5 hours with the minimal visual field defect, which is expected from going through Meyer's loop. On the left side, same scenario, looks very different. This was a 71-year-old female with 3 years of non-specific headaches, little bit of word finding difficulties. The neurological exam was largely non-focal, except some receptive aphasia and maybe a bit of blurred vision. On the initial scan, they picked up a 4 by 5 centimeter lesion, again with an entrapped temporal horn, which is sort of a theme here. We got CTA showing nicely that the internal vessels, the veins, were all displaced medially, so no risk. The vascular pedicle to the choroid is again just under the tumor and medial to the tumor. It's nicely homogeneously contrast enhancing. The most important sequence is the T2 sequence, showing you a nice CSF rim around this lesion. So it's truly separate and not infiltrative to the parenchyma and can be nicely resected. Here, if you have DTI available, very helpful because it reveals valuable aspects for your surgical access corridor. This is what I did. I studied functional MRI scan and DTI in this tumor, and all tracts were displaced. And in the DTI image, you can see that all fibers nicely splay around the tumor in the ventricle and are not compromised at all. So how do I approach this on the left side? Well, I like the left-sided parietal occipital or intraparietal sulcus axis, which is very similar to Fraser's burr hole. So you go from the inion about 5 centimeters up and about 3 to 4 centimeters to the side. You then pick a sulcus that you can identify, which gives you about 2 centimeters into the brain. And then you only have 2 centimeters of dissection across the white matter, which is, again, very safe, very familiar with short working distances and a small visual field with almost no retraction. That's what we did in this patient. You see in my tractography, I put the patient 3/4 prone and use a parasagittal axis from the back. I was able to sneak through this sulcus almost into the ventricle. We were able to do a gross total dissection and had no stroke around it on the DWI, so I was happy with my outcome. Post-op management, not different from any other intraparenchymal tumor. Some steroids, get an image set 3 hours later just to make sure there's no bleeding in the ventricle. Blood pressure control, height of bed elevated, keep the patient NPO until your CAT scan is done. And if you do see blood on the post-op CAT scan, don't be shy for a revision. So earlier in my career, this was my first case. The patient bled into the ventricle. I was worried that this may cause hydrocephalus, so I just took the patient back and cleaned this out in the same evening, left the drain behind for 24 or 48 hours. Shouldn't really cause trouble. But you need to tell the patient about this because it is more frequent to encounter hematoma in the ventricle than in parenchymal resections, and may also cause hydrocephalus or aseptic ventriculitis. So these are the typical rare side effects from this, as well as a visual field defect is possible. Now I want to show you a rare complication from a mini meningioma in the ventricle. This was a 37-year-old female that had a meningiomatosis. She already had previous 4 craniotomies for larger tumors. She was followed sequentially. KPS was 100, and of course she was a lawyer. She had no neurological deficit. So what would you do with a lesion like this? The correct answer is don't do anything, wait and watch. That's what we did, but unfortunately she had progression on sequential imaging. And because she was well read, she said she wants to be minimally treated. She had 4 cranies. For this one, the risk she felt was bigger than the benefit. So we said, okay, we can do radiosurgery. We planned this out on our CyberKnife Center. We radiated this with 13.5 gray to 80% isodose, and we were very happy with the tumor control. However, unfortunately, 3 months later, there was an inflammatory reaction to the radiation, leading to an entrapped temporal horn on the ipsilateral side. And now the patient was symptomatic with headaches. So what would you do now? We did stick to our rule of minimal invasiveness and decided to do a stereotactic catheter implant coming from lateral, going through the temporal horn and draining into the prepontine cistern. That was large enough in her case. We published this case in World Neurosurgery a few years ago. It's a very nice, elegant, minimal invasive technique. So the patient really had no significant morbidity from the surgery, and it's a very safe approach in experienced hands. Now let's move on to the third ventricle. There are a myriad of options again. I want to limit myself to 2 very common options, which is, should we go transcortical transventricular or should we go extraaxial transcallosal for lesions that are located in the third ventricle, usually anterior half. Alternatively, you may want to discuss whether you could do endoscopic surgery, which is very fashionable, very advocated. I think endoscopic surgery carries advantages such as smaller access, superior illumination because you bring the light source to the tumor, and maybe less tissue retraction, although I want to challenge that. I think it's good to resolve CSF obstructions. It's good to get a biopsy. It may even work for some resections, but lesions are not always suitable for endoscopy. I think it works better for smaller lesions, less than 2 centimeters, that are small and solid, or small and solid and cystic. But you should really have dilated CSF spaces, otherwise it's a pain in the butt to work the endoscope in there. So there are certain pathologies that are suitable for this. One is the colloid cyst. This is one of the most suitable lesions to learn endoscopy because it's completely benign, it has low vascularity, and it often comes with dilated CSF spaces and normal anatomy of everything around it. But you have to be really careful. On the left side, you see a patient with hydrocephalus, giving you good working space, and you can identify the fornix over your foramen Monro here seen from the right side really well. If you have no hydrocephalus, it's really hard to see the colloid cyst that is still buried under the foramen Monroe. much harder to operate on, maybe not the best case for the endoscope. Risk has to be minimal because most of these cases are elective. And if you miss up this case and the patient is not doing well, you have a walking business card in the community for the next 20 years of a patient that will not sing your praise. So be careful with your approach. There was an excellent paper that all of you should read by Margaitis and Suvedani from New York about 8 years ago. They compared endoscopic versus microscopic treatment. They did a meta-analysis of all published series with more than 20 patients. Mean follow-up about 3 years. The surprising thing was the endoscopic resection rate was below 80%, and the recurrence rate within 3 years was surprisingly high at 12%. Favorable was low complication rates of only 5% major complications and a low shunt rate required post-op. So I think this is a good technique, but it may be limited to some lesions. How does this compare to microsurgical treatment? Same group now looked at the microsurgical series with greater than 20 over 36 months. Here, gross total resection rate was nearly 100% with recurrent rate less than 1% in the observation period, but significantly more complications. My only criticism of the paper is that they do the pooled analysis of all types of surgeries and mixed approaches, which really is hard to compare. So I think the conclusion here is it's a much more curative approach, but there are great variations between the studies. If you go transcallosal, your risk for cognitive change is significant. Whereas if you go transcortical, you are more likely to encounter a seizure. How do I decide? And I want to show you this picture from an atlas. I think if you come in from the top down, corpus callosum transcallosally, you have a higher risk of encountering vessels on top of the corpus callosum with variations in the pericallosals, and you may not end up on the right side of the septum, and you may end up not easily identifying the fornix before you can cut the talar choroidea. I prefer a right-sided transcortical transventricular approach because the idea is if you come in at this angle from, let's say, Coca's point, you have splayed fibers, less likely to cut a fiber bundle at the same density as in the midline. You see the familiar structure, the floor of the ventricle on the right side. Here's the choroid plexus, thalamus laterally, fornix medially, easy to dissect, and you get into the third ventricle. So this is how I do this most of the time. And this is a typical case showing a high-riding, densely calcified colloid cyst with the vessels being splayed laterally. This was nicely approachable from either side. I always go from the right if I can. You see a 6 millimeter axis corridor similar to an endoscope. I don't think they're any better than a good microsurgical corridor. I was able to chisel this tumor out with no DWI signal or forniceal compromise, and the patient did well, could be discharged post-op day 2 on steroids. So conclusions for the third ventricle. Surgery is recommended for all symptomatic cysts and all asymptomatic cysts with ventriculomegaly. You should always consider all options, and whatever works best in your hand is really your go-to option. I think endoscopy does work well, especially in the posterior third ventricle. It decreases time, it decreases morbidity if you count seizures, and it shortens length of stay. But it does carry a much higher recurrence rate. So counterintuitive to what most surgeons would say, I operate young patients openly with the transcortical transventricular resection because I want to have a curative approach to a colloid cyst, whereas in an older patient doing an endoscopic decompression, fenestration is maybe good enough because they may not see the recurrence in their lifetime. Now, one brief unusual approach outside the box to a lesion in the posterior third ventricle, just to show you it can be totally different. This was a 26-year-old female with intractable headache sent to us from an outside hospital. They got this MRI scan. On the T2 sequence, they felt there was an arachnoidal cyst in the third ventricle, asymmetric on the right. They put in a catheter, like a RICAM, to aspirate the cyst, and it didn't work because they realized maybe this is not a cyst and sent the patient to us. And on a second MRI scan, we included a DWI sequence revealing that this really was an epidermoid growing in the third ventricle. I got the matching MRI scan pre-surgery and a CTA showing that all vessels were displaced to the contralateral side. The catheter was already coming in from hyperradial, and there was a very nice corridor with no vessels whatsoever from the right side. So I decided to take this out transcortical, transventricular, and just follow this catheter. This is what we did. We basically came in from the side, worked here in the ventricle, and although this is an intraaxial access, I really obtained perfect viewing angles to chisel out all of the tumor and leave all other vessels behind, and I had a very suitable approach. I do understand that this is higher morbidity than an extraaxial approach, like a velum interpositum approach from posteriorly, but I think you need to, at that time, think what works best in your hands, and I made the decision that this patient would benefit from this procedure, and luckily she did well. Now I'm more experienced, I may pick the velum interpositum approach. Last part, infratentorial lesions, the fourth ventricle. This is a challenge even for experienced surgeons, and you need to know, again, there are several routes to get in. It all started with Dandy, who just said, go through the midline, you have perfect access, best viewing angles, you can chisel out whatever needs to come out of there. Well, there are other approaches besides the transvermian midline approach, especially if the tumor is a little bit more laterally. People have tried far lateral transcondylar approaches, but both of these are technically hard and associated with high morbidity. So what's really recently championed, and I think this is the go-to approach of all, is a telovelar approach for tumors reaching the fourth ventricle and the CP angle. I take you again through our route of options and anatomy with the associated risks, but I want to tell you it works really well for tumors sitting in the foramen luschke laterally, as well as those sitting in the midline smack in the fourth ventricle. Neoplasms, again, as we mentioned before, anything is possible in this locale, so it's very versatile no matter what you encounter. And as I said, the infratentorial options started off with Dandy through a midline approach, and the midline approach was initially thought to be very effective and very fast. I still do it sometimes for large bleeds in the ventricle where time is the most important thing, but it's really associated with high morbidity. There's an akinetic mutism called a speech compromise with cerebellar mutism, which is a combination of aphonia, dysarthria, ataxic speech, as well as truncal hypotonia and some behavioral changes that is not worth going for. If you can, use the cerebellomedullary fissure approach that was really championed in the group around Roton in the 90s. And this is the initial paper that presents this case by Matsushima. The idea is you want to avoid splitting of the vermis at any cost and use natural planes to get into the fourth ventricle. This is what you really want to achieve. This is a view of the fourth ventricle from behind. The obex is in the middle. You want to gain access to the body of the fourth ventricle, up to the aqueduct, laterally towards the lateral wall, and even into the lateral recess. First, define what is your cerebellomedullary fissure. It's really the space between the uvula and the tonsil, higher up, and it's the space between the medulla and the tonsil lower down. So we want to open up this fissure, which is a natural cleft that is almost avascular. Here I put together for you for the boards again, what are the boundaries of the cerebellomedullary fissure. It really is the roof of the fourth ventricle, the inferior mellum, the tenia, the foramen magendi sits in the midline, the fourth ventricle body sits under it, the lateral recess and limbus is laterally formed to the foramen luschke, and what's in it? The pica and branches of the veins of the cerebellomedullary fissure. Now, surgical steps, if you do one side, you can do a lateral approach for foramen luschke tumors. And if you do a bilateral approach, I prefer a midline approach, which can be either upside down or regular, like a Chiari decompression, exactly the same surgical access, very familiar to all of you. I do intraoperative monitoring for all of these cases for the cranial nerves, as well as direct nerve stimulation and MEPs. And in cadaveric chapters, you can really review the anatomy nicely. The idea is to get the same exposure you would choose for a Chiari decompression. So this is how we want to approach this. When you look at this at a first glance, it looks like a mess, but if you break it down into steps, it's 4 simple steps. Step 1, You identify the tonsil and the medullary fissure. You put a retractor after you take the arachnoid out, put a retractor in there and elevate the tonsil 45 degrees up and out. I use a Greenberg retractor with Ruggles blades or Fukushima blades. Then identify the obex and the talar choroidea with the vessel here, make a 45-degree cut out, so first bipolar and then split, and then you can elevate the entire roof of the fourth ventricle. This is how this looks in the lab. Again, identify the uvula, split the tonsil laterally, identify the talar and the fourth ventricle exit, go from the obex and go anteriorly at 45 degrees lateral and out. You can then free up the wall of the floor of the fourth ventricle. And if you need to get into the limbus and the lateral recess, you just extend your opening. You can do either extensive openings for bilateral approaches that I had shown you, then you end up lifting the entire roof of the fourth ventricle off, or you can do it unilaterally, or you can do it only for the foramen Luschke. So it's a very variable approach. I want to recommend to all of you also this paper by Tomasello that has a beautiful drawing as well as a matching video clip with it. It's a good review paper in World Neurosurgery from 5 years ago, worth for all the learners to watch. This is how this looks in real life. When you look from the back, the tonsils have been elevated. You see the obex down here, the floor of the fourth ventricle, the tumor sits there. Think about 45 degrees lateral and out, buzzing the choroidal planes, and then you can split this. These are 4 examples for tumors where this worked nicely. This is a meningioma WHO grade 2, high riding in the fourth ventricle. We were able to do a very steep approach. So the patient was in the prone position in military flexed neck, and we were able to not cut a single plane that required fibers or would create a deficit and take this tumor out. This is a pediatric patient in a kid with a solitary fibrous tumor. Same concept, coming in from inferiorly. You don't leave any major troubles behind. This is the more typical case, an ependymoma WHO grade 2. Mind you, here on the right side, you see the CTA and the post-contrast images of the pica being intimately involved in this tumor. You have such a good view that you can chisel out the tumor and leave the pica flapping in the breeze afterwards with no compromise to the patient whatsoever if everything goes well. If you want to do a unilateral approach only, I told you, you can just open the talar choroidea on one side. Again, identify the obex 45 degrees and out. Sometimes you have to transpose the pica, but you get access into the lateral wall of the lateral fourth ventricle. It works for tumors sitting right in the foramen Luschke on either side. It also works for cavernomas, and it's very suitable. Just before I finish, the 2 last pictures are about rare cases I saw in this location. This is a young man that came to me with swallowing difficulties, ring-enhancing lesion in the fourth ventricle. I really didn't know what this was. I decided to get high-resolution T2 images showing that there was the cystic lesion right under an emerging cranial nerve. I couldn't really tell, was it 9, was it 10, what was happening down here. I obtained pre-surgical CTA showing me low vascularity and displaced vessels. I got a DTI showing me all fiber tracts were displaced, so the pyramidal tract was displaced deep and anteriorly as well as contralaterally to the tumor, which allowed me to come in from posterior, and the emerging nerve was the 10th nerve from this location. We did this case monitored as a telovelar approach on one side. We got 90% of the tumor out, came back intraoperatively as a ganglioglioma WHO grade 1. The only portion I couldn't take out was the floor of the fourth ventricle laterally, because each time I touched it, the 10th nerve was buzzing like crazy, and I didn't want to compromise the patient with a benign lesion. So I think we made a good decision here, and the patient has not recurred yet since. Lastly, rare extraaxial tumors such as an epidermoid filling the P fossa can also grow in this area of the fourth ventricle and then wrap around the brainstem through the foramen Luschke. Also a case very suitable for a telovelar approach. You can see that we were able to sneak through natural planes just like a Chiari approach from an axis perspective, telovelar unilateral to take out the foramen Luschke. We got a gross total resection. The patient did really well. Conclusions, I think intraventricular surgery is actually fun and it's not scary. I think you need to think inside the box and know your anatomy and be safe and pick approaches that you know well and really study your anatomy as much as possible, but also think outside the box and be versatile with your approaches, unilateral versus bilateral, and use some common sense. You will see it's rewarding. Thank you very much.
Thank you, Professor Eckenhardt. We have witnessed a truly impressive presentation. Thank you so much for sharing with us. At the end, we learned a lot to how consider different situations. We must provide patient-specific multi-approach strategies derived from tumor pathology, area of involvement, to design the less invasive method with the most helpful approach to surgical technique considering our experts. Thus, patient and tumor profile will guide the technique selection to be employed. Thank you so much. I don't know if we have time for any questions,
I
Raya.
think we can go to the next speaker because we are already
Perfect,
exceeded
of
45 minutes.
course,
You may
I
Good.
please
agree.
invite Professor Shu Feng.
Next speaker, Professor Xu Feng, Associate Professor, Department of Neurosurgery, Huashan Hospital, Shanghai Medical College. The professor was widely presented by Raya. So thank you, Professor Xu Feng. Go ahead with your talk.
Okay. Good evening. Thank you for
Good
the
evening.
invitation. So today we'll talk about the secular anterior communicating artery aneurysm classification and clipping strategy. The anterior communicating artery is the most common location for intracranial aneurysm, and a ruptured aneurysm of this artery accounts for 40% of aneurysms with not hemorrhage. The endovascular coiling has emerged as a feasible option for ACOM aneurysm. However, the endovascular treatment of the wider neck ACOM aneurysm remains technically challenging. Adjunctive techniques such as the multiple microcatheter or micro-guided wire protection technique is a safe and effective treatment for wide neck aneurysm, especially for the acutely ruptured wide neck aneurysm. Here is a case of the wide neck unruptured ACOM aneurysm, and we used two microcatheters were inserted into the aneurysm sac, and post-embolization, the aneurysm was totally occluded. The balloon remodeling can be considered for the broad wide base complex ACOM aneurysm. And this technique provides a high rate of aneurysm occlusion with a low complication rate and avoids the need for dual antiplatelet therapy. And the three trajectories can be used. The contralateral trajectory from the left A1 to the right A2. Ipsilateral trajectory from the ipsilateral A1 to the ipsilateral A2. Or the crossing balloons can be used. And recently, the Stent assist coiling is an alternative treatment option for the wide neck ACOM aneurysm. The stents can be placed in three routes from the ipsi-A1 to the contralateral A2, from the ipsilateral A1 to the contralateral A1, and the last is from the ipsilateral A1 to the contralateral A2. We talk about the why Stent technique. And why Stent technique, including the crossing wide stent or kissing wide stent, is a promising therapeutic option for the wide neck ACOM aneurysm. And recently, X-configured stent is another novel therapy for the wide neck ACOM aneurysm, or T-configured stent. And we also use the intracranial, extracranial stent to treat the complex ACOM aneurysm. It's also called the ice cream valve cone technique. Recently, the fluid diverter is also used to treat the complex, the wide neck ACOM aneurysm. And according to the anatomic and morphology of the ACOM and the bilateral A1, the diameter of the bilateral A1, the authors divided the ACOM aneurysm into 4 types. And the authors thought that the most suitable and anatomical configuration for fluid diverter treatment seemed to be the H1 configuration, and using the I technique from the IPSI A1 to the IPSI lateral A1 A2, the fluid diversion. Now, they also concluded that the H3 type is not suitable for the fluid diverter. Recently, a meta-analysis compared the endovascular and microsurgery treatment for the unruptured anterior communicating artery aneurysm was published. The rate of the angiographic recurrence of the microsurgical is lower than that in the endovascular coiling. So I think the microsurgical is still an important tool for the treatment of the ACOM aneurysms. And understanding the anatomy and morphology of the ACOM artery will allow the neurosurgeon to construct a better operation plan and ensure the safe clipping. And in 1992, the NETA classified the ACOM aneurysm according to the projection of the aneurysm. They divided the aneurysm into 3 types. The type 1, the aneurysm located anterior to the bilateral A2. Type 2, between the bilateral A2. And the type 3, the posterior to the bilateral A2. And Professor Hanasmi Yuha in 2008 classified the aneurysm according to the projection of the dome into 5 types: the downward or toward the skull base, a forward or frontal, upward or intertruncal, the backward or occipital, and the last one is a complex involvement of the ACOM artery. Also, the same-year, the Suzuki classified the aneurysm according to the relationship between relationship with the parental artery on the lateral angiographic view. They divided the aneurysm into 2 types: the superior type aneurysm and the inferior type. And the superior type aneurysm was subdivided into the anterior from 0 to 5 o'clock, and the dorsal type from 9 to 12 o'clock. And in 2011, Michael Lawton and the professor classified the aneurysm, ACOM aneurysm, into the superior, inferior, and anterior and posterior 4 types. And then another researcher classified the ACOM aneurysm. They drew a line through the ACOM and parallel to the skull base. Then they drew a line through the ACOM and perpendicular to the parallel line that divided the aneurysm into anterior, superior, posterior, and inferior types, also the 4 types. And our classification is consistent with previous studies. And in 2016, NOSCA classified the superior type into three types. They proposed a microsurgical classification system for the superiorly projecting ACOM aneurysm based on the virtual plane created by the both A2 segments and its relationship with the aneurysm dome. The virtual two-dimensional plane formed by the proximal A2 segment has two potential axes within the superior quadrant. The green pivot axis describes the potential moment from the coronal to axial plane. And the blue pivot axis places the virtual plane orthogonally in the sagittal axis. So we modified this classification with a minor revision. And we divided the superior projecting aneurysm in four types. The type 1 is anterior-superior type. The dome of the aneurysm is located anterior to the virtual plane, the virtual proximal A2 segment plane, and yet remain completely within the superior projection quadrant. And usually a straight clip was used to clip the aneurysm. And type 2, intertruncal. The aneurysm is essentially centered in the superior projection quadrant and is bisected by the plane created by the proximal A2 segment. Part of the aneurysm dome is anterior to the both set A2 segment, and part of the aneurysm dome is posterior to the virtual A2 segment. And type 3 is posterior-superior type. The dome of the aneurysm is completely posterior to the virtual proximal A2 segment. Is posteriorly and is closely associated with the ACOM perforators. Usually, a fenestrate clip is placed encompassing the proximal ipsilateral A2 segment, and the distal clip blades lie posterior to the contralateral A2 segment. And type 4 is defined by the sagittal rotation of the virtual plane formed by the proximal A2 segment. In the 4A, we call it the open A2 plane. From the view, the ipsilateral A2 is positioned posteriorly, and the contralateral A2 segment is anterior to the dome. So the aneurysm is clipped with a straight clip. And the type 4B is a closed A2 segment. The ipsilateral A2 segment is anterior to the aneurysm dome, and the contralateral A2 segment is posterior to the dome. A fenestrate clip is usually used to reconstruct the ipsilateral A2. Then we show some illustrative cases. The case 1 is anterior type. From the interrupted operative view, it shows the ACOM aneurysm, and this is a ipsilateral A2, ipsilateral A1. And a straight clip is used to clip the aneurysm, and we expose the right A1, A2, and the left A2. And the aneurysm was resected. This is the left A1, A2. And the case 2 is inferior type. And this is the CTA before operation. And this is a coronal view and the sagittal view. We can find we can find the aneurysm is facing toward the inferior. And the oblique other view of the aneurysm. And we perform the posterior approach, and we usually achieve the temporary control of the proximal A1. And after exposing the ipsilateral A1, the aneurysm dome was totally exposed. And we first perform the pilot clipping. Use a straight clip to temporarily clip the aneurysm. Then we try to expose the contralateral A2. And we incise the aneurysm and then remove the intra-aneurysmal thrombus and expose the contralateral A2. This is the contralateral A2. And this is the final clipping of the aneurysm. This is ipsilateral A1, contralateral A1. And this is a post-operative angiography shows that aneurysm is totally complete obliteration of the aneurysm, no recurrence. And case 3 is a anterior superior type, is a type of 1. And this is a CT scan shows sublunar hemorrhage. And then preoperative CT shows aneurysm projecting the anterior superior. And this is a DSA before operation. And we used as the patient was positioned supine and the aneurysm was exposed via the lateral supraorbital approach. And this is the intraoperative view. There's an aneurysm dome and there's an A2, ipsilateral A1, A2. And we expose the contralateral A2 and a straight clip was used. And totally, this is the final clipping. And this is a video. For an emergency case, we usually open the carotid system and the optic system to release the cerebrospinal fluid and achieve the adequate brain relaxation. And a subpure resection of the gyrus rectus was performed to visualize the ipsilateral A2 and the aneurysm, the base of the aneurysm. And this is the recurrent artery of the humena. A temporary occluded the A1. And the a plane was dissected between the anterior aspect of the both A2 segments and the posterior aspect of the aneurysm dome. A straight clip was placed parallel to the ACOM to completely obliterate the aneurysm. And the patient recovered well without any complications. And this is another case of the type 1, the anterior superior projecting aneurysm. This is a CTA before operation. And then we temporarily occluded the bilateral A1, and we found the aneurysm located in the anterior superior. This is ipsilateral A1, A2. And what we dissected as a plane between the aneurysm dome and the both A2 segment. This is the contralateral A2. So also we use a straight clip. And finally, we resected the aneurysm. And this is the ipsilateral A2, contralateral A2, contralateral A1, ipsilateral A1. And if it is difficult to dissect the plane between the distal neck and contralateral A2, a tandem clipping can be used. And this is an illustrative case. A ruptured aneurysm, the DSA demonstrates the anterior superiorly projecting ACOM aneurysm. And we use the lateral superior orbital approach. This is the right to A1, the ACOM, and the right to A2. This is the aneurysm. The left to A2 is obscured by the aneurysm dome. Here we can see the left to A2. And we dissected the plane between the distal neck and the aneurysm dome. We use a straight clip to perform the pilot clipping. And we found it was difficult to dissect the plane between the distal neck and the contralateral A2. So we used another straight clip to tandem clipping the aneurysm. This is the final clipping. And the post-operative, the 6 months after the operation, the DSA demonstrated no recurrence of the aneurysm. And this is a case 6, is a type 2, a superior type, intertruncal type. And this is the DSA before operation. And intraoperative, we found the aneurysm is bisected by the bilateral A2 segment. A fenestrate clip was used, and we resected the aneurysm dome. We found that contralateral A2 was temporarily clipped, so we adjusted the first clip. We used another fenestrate clip to clip the aneurysm dome and adjusted the first clip. This is a final clipping. We used 2 fenestrate clip to clip the aneurysm. And the patient recovered well. And this is an intraoperative video. And this is the aneurysm. The contralateral A2 is obscured by the aneurysm, and we expose the medial aspect of the ipsilateral A2. We try to expose the contralateral A2. And now we resected the aneurysm dome. and to expose the contralateral A2. And we found the contralateral A2 was temporarily clipped. The aneurysm was punctured. Then we adjusted the first clip. At last, the two finisher clips was used to reconstruct the ipsilateral A1. The aneurysm was completely obliterated. And the case 7 is the type 3. The aneurysm is posterior to the bilateral A2. And from the intraoperative view, we can find the aneurysm dome is posterior to the bilateral A2. This is the final clipping. Use the finisher clip. This is the intraoperative video. And we first, after we temporarily occluded the left A1, we try to use a curved clip to clip the aneurysm. Now we are exposing the plane between the aneurysm dome and the bilateral A2. However, the intraoperative bleeding, the aneurysm rupture. And we also temporarily occluded the contralateral A1. We want to adjust the curved clip, but it's still bleeding. So we take out the clip and we use a finisher clip. After removing the temporary clip, the aneurysm was completely obliterated and stopped bleeding. And this is a post-operative 6 months angiographic follow-up showed no recurrence of the aneurysm. And this is a type 4A, the open A2 plane. The case is also a ruptured aneurysm. And this is the intraoperative view. And the contralateral A2 is anterior to the dome, and the ipsilateral A2 is posterior to the dome. So a straight clip was used to clip the aneurysm. And this is a angiograph follow-up shows no recurrence. This is another case of the superior type 4A. And the aneurysm was, we can find the irregular shape of the aneurysm with multiple lobe. And this is a contralateral A2, the ipsilateral A1, and the ipsilateral A2. And this is the aneurysm. The two lobes of the aneurysm. And a straight clip was used to clip the aneurysm. And we expose the aneurysm dome and puncture the aneurysm to confirm the complete obliteration of the aneurysm. And this is the intraoperative video. And we first open the optic system to release the cerebral spinal fluid to achieve the brain relaxation. And the carotid system is also open. This is the ipsilateral optic nerve, and this is a contralateral optic nerve, and this is a contralateral A2. And we found the contralateral A2 is located anterior to the aneurysm lobe. And we resected, remove some superior removal of the gyrus rectus to expose the ipsilateral A2. And we temporarily occluded the A1, ipsilateral A1, and continue to remove some gyrus rectus. The plane between the neck and the ipsilateral A2 was exposed. And we coagulated the aneurysm dome to shrink the aneurysm. And we continues to expose another lobe of the aneurysm dome. It's irregular shape. We can find the total appearance of the aneurysm. And we used a straight clip. The temporary clip was removed. You can see the aneurysm was completely obliterated. This is a Doppler to confirm the preservation of the flow of the bilateral, and then we puncture resected the aneurysm to confirm the complete obliteration. And this is a postoperative CTA showing no residue of the aneurysm. And this is a case 10. The 4B type is closed A2 type. And after temporarily occluded the left A1, we expose the left A2 and the aneurysm. We found the right A2 is posterior to the aneurysm dome, and the left A2 is located anterior to the aneurysm dome. A fenestrated clip was used to perform the clipping. And the post-operative follow-up angiography showed no recurrence of the aneurysm. And this is a case 11. It's also a 4B type. And this is a three-dimensional image of the DSA. A fenestrated clip was used. And this is an intraoperative video. Also, we opened the optical system and the carotid system to release the CSF. And we continue to open the optical chiasm. And the ipsilateral, the proximal A1 segment was the distal segment of the ipsilateral A1 was exposed. And we superior resection of the gyrus rectus was performed to expose the ipsilateral A2. And we also expose the medium surface of the ipsilateral A2 to expose the contralateral A2. You can see that the contralateral A2 was exposed. And this is an aneurysm. The aneurysm was located in the ipsilateral A2 was located anterior, and the contralateral A2 was located posterior. We try to dissect the plane between the distal neck, between the aneurysm dome and the contralateral A2. A fenestrate clip was to reconstruct the ipsilateral A2. And the blade of the clip is located anterior to the contralateral A2. This final clipping. The case 12 is complex involvement of the ACOM artery, and the CT scan shows the right frontal ham tumor. And the DSA demonstrates a complex ACOM aneurysm with multiple lobes. And this is a three-dimensional image showing the multiple lobes of the aneurysm. And the intraoperative photo showed with two aneurysms. One aneurysm facing toward the inferior and another facing toward the superior. Then we first use a strap clip to clip the aneurysm downward. And we also use a mini clip to clip the aneurysm facing superior. The bilateral A2, the ipsilateral A1 was preserved well. And this is final clipping. And the CTA postoperative CTA should know residual of the aneurysm. And last, we introduced a recurrent embolized aneurysm. This is an ACOM aneurysm. The patient received the previous embolization. And the follow-up angiography shows maybe remnant 2 and a recurrent the aneurysm. And this is a three-dimensional image of the DSA. And this is the intraoperative photo and the ipsilateral A2. This is the aneurysm. And this is a coil. And the contralateral A2. We used a fenestrate clip to clip the aneurysm. And we also removed the coils. Then another fenestrate clip was a tandem clipping the aneurysm. And this is the ICG, shows the patency of the bilateral A2. Thank you. Thank you very much.
Suriano.
Thank you, Professor Xu Feng. Nice presentation. I think the time is over, but I don't know if Raya
I
can allow us
Yeah, we
to
can
make
sure
questions or
take a
something.
few questions from the audience. Definitely, we can question. Discussion can be
Can I
open
ask a
for.
question?
Yes, Professor. Sure.
Is Professor Casper around or has he gone?
Yes, he's here. Professor
Is
Casper.
there. Right? Okay, I have questions to both the speakers. To Professor Casper, what a wonderful lecture as usual. And Professor Casper, do you say what is your indication for doing angiogram for intraventricular meningioma? And in your long years of experience, have you seen any velum interpositum meningioma in the third ventricle, which is a mimicker for falcotentorial meningioma? Both are grouped together as the pineal region meningioma. So have you seen a velum interpositum meningioma? And what is your indication for angiogram in intraventricular meningioma? First question. Second question to Professor Casper is, what is your tricks for avoiding cerebellar mutism? These two questions to Professor Casper.
The role of angiography, conventional DSA in meningioma is essentially nil. I don't think you need it these days. I think if you have good CTA, you can get most information out of it. I'd say in a posterior third ventricle tumor that seems to be large and sort of the internal veins draped over it, an angiogram may be helpful because you get additional data out of it, but in meningiomas, in principle, not necessary. I think that's an exceptional case. I did one last month where I had a Sturge-Weber malformation over the cortex and a left-sided large intraventricular tumor. So there I did an angiogram. I wanted to understand the vascular anatomy, and I'm going to present that case at the next World Federation anatomical seminar. Velum interpositum meningiomas, I've seen one in my practice, so extremely rare. I'm not sure, why other people see more of them, but I would say exceedingly rare pathology. And depending on whether the internal veins are depressed below the meningioma or elevated above the meningioma, that decides where your surgical corridor will be. I rely as much on advice of experts in these occasions as probably you do. But I think a formidable challenge, falcotentorial meningiomas, I think are some of the most complicated lesions to operate on, and preservation of the veins is the most relevant thing to learn from there. And with respect to telovelar approach, I have not seen cerebellar mutism with the telovelar approach. I've heard other colleagues that claim they still see it. I think it is more likely to be from a retraction injury if they encounter this. But I think a diligently done telovelar approach has essentially no complication rate to the cerebellar parenchyma unless you lose a vessel.
Thank you. So my comments to your thing is, especially as you correctly told, angiogram will show medial posterior choroidal for a velum interpositum meningioma, and the feeders for a falcotentorial, which is a mimicker of that, will come from extracerebral, mainly tentorial vessel. And as to the displacement of a falcotentorial one, both internal cerebral and medial choroidal will be displaced down. While for a velum interpositum, as you correctly told, internal cerebral vein will be shifted up, while the choroidals will come down. So that is one way you can make out whether it is velum interpositum or falcotentorial. And regarding cerebellar mutism, is it necessary that patient should have bilateral dentate nucleus or outflow damage, or it can happen only with unilateral damage?
So I've heard that unilateral damage to the dentate is bad enough to cause mutism and cognitive decline. So I'm sure it happens. I'm not sure when it happens, because if you do a diligent telovelar approach with minimal traction on the roof and the parenchyma of the cerebellum, there should be no injury to the dentate. But yes, I've spoken to colleagues that say it does still happen. Maybe if the tumor is large and has distorted the anatomy and your viewing angle isn't optimum, At some point, you need to make a decision. But I think the incident rate is so much lower than in midline transvermium approach. I've abandoned transvermium approaches altogether, except if there's massive hemorrhage into the fourth ventricle or into the cerebellar midline from an AVM or anything, and you just have to be fast, otherwise the patient dies, right? That's the only exception.
To Professor Fung, 3 millimeter ACOM incidental aneurysm. You observe or you just go ahead with some management?
Thank you for raising such a question. The shape is the most important factor for aneurysm rupture. If the aneurysm diameter is 3 millimeter, and if with the irregular shape, we will recommend the treatment. And some cases of the ruptured ACOM aneurysm is less than 3 millimeters. So if the patient has the hypertension, or we may recommend the high resolution MR image to show the enhancement of the aneurysm wall or anything else. We maybe recommend the patient to receive this treatment, not a conservative.
And my second question to you was, you always choose the side of A1 dominance, or you go from the side of open 4 for your type 4A, and for type 4B from the side of closed 4. I don't know what is your way of deciding the side of approach for
yeah. Actually, the operation, the surgical approach is determined by the personal experience. So we usually choose the dominant A1 artery approach. So if you, as you said, the type 4 is easy to treat this type aneurysm, and this is if the lateral A1 is non-dominant, we can use a contralateral approach to treat the aneurysm. So we usually use the posterior or lateral superior orbiter. And sometimes I think the inter-hemisphere approach is also recommended.
Thank you so much, Professor Shufeng. We wish to have all our audience to participate, but since there is lack of time, we will have only a few comments. I will invite my co-host, Dr. Liu Boon Seng, to say his comment or question. Dr. Liu.
Yeah, Professor Kespa, thanks for your nice presentation. Just a very.
I have to apologize. I didn't hear that question.
The second question was, what is the best position for operating on a colloid cyst?
Oh, I personally put the patient supine in pins with the head up straight midline. Because if I go from Coca's point, which is essentially what I do for a right-sided approach, I think keep your anatomy as straight and orthogonal as possible. So especially when I teach my residents the early stages of tumor surgery deep in the brain, I say keep the head as either perfectly straight or perfectly 90 degrees lateral position, because you get a better idea about distances if you keep the relative positions orthogonal. And you need to gain experience with depth in the brain if you lose your plane. And that's why image guidance is not a shame to be used initially. If not every center has it, I understand. You go with the landmarks that are used to, how to follow best trajectory into the right frontal horn of the lateral ventricle. And that's best achieved if you don't tilt the head at all, right?
Right. Thank you so much. Professor Shufeng, I would wind up with one question to you. What is your strategy in blister aneurysms of ACOM?
Blister aneurysm of the ACOM aneurysm?
Yes.
Yeah. I read the paper from the PubMed, the blister ACOM aneurysm. Actually, I didn't encounter any one case of the blister ACOM aneurysm.
Okay, thank you. That's fine. Before we end, we will take one comment from Professor Shubin.
Raja, today we have around 700 audience watch this broadcast of the webinar. And totally we have 1,800 readers read the introduction of this webinar. So last time, now totally there were around 3,000 audience to replay the webinars of last time. So it's good news.
Thank you so much.
Question for Professor Shufeng.
Yes, please.
Professor Shufeng, how impressive, because there are too much classifications of the ACOM aneurysm. So my question is how those classifications are going to become better prognosis, or what is the idea? Why so many classifications?
Yeah. Actually, the classification is we divided the ACOM aneurysm into anterior and superior, inferior, and posterior. Actually, and the last, just as you asked me, you professor recommended the complex, the 5 types, but I focused on the superior projecting aneurysm. Because the superior projecting ACOM aneurysm is most difficult to treat. The anterior and the inferior projecting ACOM aneurysm is easy to treat. I think most of the neurosurgeon can easily handle this aneurysm. But sometimes the superior projecting aneurysm, ACOM aneurysm, is hard to expose, especially for the contralateral A2. Is always obscured by the aneurysm dome. So I focused on the superior projecting ACOM aneurysm and subdivided it into the 4 types. And this is my personal, not account for all of us. I'm sorry.
Okay, thank you, Professor.
So much. Yes, Professor. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers for today, Professor Eckhard Kasper and Professor Shu Feng, and the chair, Professor Jose Antonio Soriano Sanchez, for taking their time and coming here and teaching us about intraventricular tumors as well as surgical strategies for clipping of anterior communicating aneurysms. Thank you, Professor Shubin, for webcasting this through China and constantly supporting us throughout our journey. Thank you, my dear co-host Liu Bun Seng, for being my co-host for today. So until we meet on next Wednesday, it is bye-bye from all of us.